As the first point of contact within the healthcare system, primary care professionals play a pivotal role in identifying symptoms consistent with cancer and reducing diagnostic delays. Yet, as was highlighted in CCRAN's 2024 Symposium, gaps in education and awareness of early age onset cancer in primary care persist. This next discussion is dedicated to ensuring cancer is considered in the differential diagnosis earlier in the clinical journey. However, a discussion on detection readiness in primary care, we'd be remiss to not delve into the unfortunate reality that many younger adults in Canada do not have consistent or timely access to a primary care provider, which further compounds delays in cancer consideration and referral. Through this next panel discussion, considering cancer in younger adults, we will delve into discourse on strategies to elevate awareness and detection readiness in primary care. We extend a warm welcome to Dr. Aisha Lofters, family physician and CIHR Applied Public Health Chair, who is kindly moderating this panel. We welcome as well Michelle Burleigh, leukemia survivor and co-chair of the Canadian Immunocompromised Advocacy Network and Cancer Action Now. Dr. Paul Dillon will be joining us shortly, who is a rural family physician and 39 Brigade surgeon with the Canadian Armed Forces. Trudy Matway, nurse practitioner in the primary care program and director of primary care with the Nurse Practitioners Association of Alberta, and Joan Hetherington, acute care gastroenterology nurse practitioner at the Red Deer Regional Hospital. So welcome, panelists, and over to you, Dr. Lofters.
Thank you very much, and thanks to everybody who is joining us online, and welcome to our panel about considering cancer in young adults, elevating awareness and detection readiness. And as was mentioned, I'm your moderator for today, Dr. Aisha Lofters. We do know that in our healthcare system right now, primary care really is the first point of contact, and as such, primary care plays a crucial role when it comes to screening, early detection, prompt diagnosis, prompt referral to specialist care, and perhaps most importantly, advocating for our patients' needs. But when it comes to cancer in younger adults, so people less than 50, this is often not on primary care providers' radar. So we know that improving the role of primary care in early identification of cancer among young adults has to be a critical system priority. So over the next hour, we want to explore how Canada's health systems can better equip primary care with the knowledge, the tools, and the confidence to recognize cancer in younger adults and to support early detection through education, clinical support, and integrated care pathways. What we want to discuss today is how can we enhance cancer awareness and risk recognition in primary care settings? What are some practical strategies to embed earlier referral pathways within frontline care? Talk about the system-level barriers that contribute to late cancer recognition in younger adults, and think about how the delays in cancer consideration contribute to system inefficiencies and to patient frustration. But to start us off and to set the tone, I would first like to ask Michelle Burleigh to share with us a bit about her journey to diagnosis.
Thanks so much for having me today. I want to just start by saying thank you so much to all of the physicians who are here today having this conversation. We hear a lot about patients who have experiences with being dismissed and minimized in healthcare, and that can be really discouraging. And to see so many physicians who are engaged and wanting to have this conversation and wanting to support and help is really appreciated. So my name is Michelle Burleigh. I am actually an acute promyelocytic leukemia survivor. I was 9 days from my 37th birthday when I was very abruptly diagnosed and admitted to hospital for my treatment. You know, life was busy at the time, like many of our lives are. My children were 5 years old at the time. I was in the height of a very successful career in the banking and investment space when I started feeling unwell, really tired. Things really started to get rolling when I went to the gym for the last workout that I did before my diagnosis, where it was very difficult to get through that workout. And then I experienced a locked muscle in my hip. It was locked for nearly 24 hours before I finally caved and went to the hospital and had a conversation with the ER doctor at that point, who asked a couple of questions. Honestly, I didn't think it was a big deal at that point because I've experienced issues with my back and hips most of my life. However, the lock in that muscle persisted for a number of days, which led to me having touch points in the healthcare system repeatedly over a very short period of time. And unfortunately, through many of those touch points, I was either redirected, dismissed, or minimized myself. Even to the point where I, as a particularly assertive person, started doubting whether I was the one who was over exaggerating, or maybe, I was just being a wimp, right? So what? I was in pain. Everybody has pain. So move on and do what you need to do in your life. Unfortunately, my condition continued to deteriorate, and after being on a number of medications, and one of them being a non-steroidal anti-inflammatory, I started bruising. And then 48 hours after bruising started, my blood vessels started bursting and I started hemorrhaging. That led to my sixth touch point in the healthcare system within about a 1 week period. And even at the time that I sat with the triage nurse, I had to fight with the triage nurse to even see a doctor that day. I remember her very specifically saying to me, um, um, well, I guess we're not very busy here today, so I suppose we can take some blood, after me pushing and pushing and pushing. And it was just about 2 hours after that that I was finally, the doctor came in the room after doing blood work, and she asked me if I wanted to have anybody there to have that conversation. And I said, listen, we don't have time, so let's just get down to it. And she shared with me at that point that I did have leukemia. And to be honest with you, at that point, I didn't really know much about leukemia, and I was positive that I would not survive it. And so, as you can imagine, it was a very difficult day, and a lot of panic. And what do I do with my children? And what do I do about this career that I'm in the middle of, and progressing in and doing so well in, um, it was chaotic. It was very chaotic, and it was very scary. And I'll even tell you that at the point that the preliminary diagnosis came back and the doctor was trying to find a hospital who could readily take me, the triage nurse did come back into the room after the fact and said, "So I guess it's a good thing you insisted on seeing a doctor." That's it. This was my entry point into the healthcare system as a cancer patient. So while I had to figure out what to do with my very young children and what would happen to my career, or whether I would even live through it, I also had to worry about the people who were tasked to help me were actually going to help me. I have the great fortune of having nearly 25 years experience in the banking and investment space, where much of my focus was in relationship management, business development, as well as operational process improvement. My job was actually to go into the office of financial advisors and branches to assess their operational businesses for how efficient they were, and then support them in changes to improve their business efficiencies. Going through the Canadian healthcare system myself as a cancer patient, my treatment plan was just over 2 years. I endured 96 rounds of chemotherapy, and I could not even tell you how many different types of medications or pills over those 2 years. In the time that I spent in the Canadian healthcare system, I was able to observe what was occurring in their processes and identify where some of the failures were occurring with my own care. I will say that there were so many really fantastic people who were supportive and really helped to reestablish trust for me in the healthcare system, but also recognize that there are some points of opportunity as well. And very, very excited to have this conversation today and looking forward to seeing what we can do about these opportunities to improve detection of cancer in early onset cancer patients. I'll just finish very quickly by saying today I am cancer-free, and I have left my banking and investment career behind and am now fully dedicated in healthcare advocacy and consulting. So thank you for welcoming me here, and looking forward to the conversation.
Thank you so much, Michelle, for sharing your story. I think as all of us who are healthcare providers are struck by what you experienced, and I think it really is important to have stories like this to illustrate why are we here today and what is it. This has real world impact on people's lives and trajectories. So thank you. Now I'm going to ask all of the panelists actually to address a question. And that question is going to be, from your perspective, and everyone's coming from slightly different perspectives, what are the system level barriers and challenges that contribute to delayed diagnoses for cancer for younger adults? And maybe let's start with Dr. Dillett.
Sure. Good morning, everyone. Yeah, so just even within that story at a systems level, it's that entry point into care. So those challenges you talk about where you've seen the triage nurse and they know that they only have, especially in small rural hospitals, there's one doctor and one nurse when you're talking about really rural. So just that simple access point into care where then the physician and the nurse have the time to really think about not only what's most likely, but what are those, we call them zebras. So when you hear hoofbeats, you think horses. So you think the most common thing first. But in a lot of cases, if you have a bit more time to spend with the patient or that longitudinal relationship, so system level, having a family doctor, when you come in and you're saying, I know something's wrong, the family doctor knows you well enough at that stage that they're going to go, okay, yeah, like your body, that there's something wrong and we need to do a little more digging. And then the other system level thing in Canada is geographic. It's just simply the time and space that people have to move through. Michelle gave a great example of you have kids at home, you have a job at home. And then how do you, if you're a rural farmer in Saskatchewan, all of a sudden have to go do some sort of cancer screening or a colonoscopy, you're going to say, the weather's bad, I can't drive. So that's 1 week or 2 weeks. It was farming season, so you absolutely could not leave and you'll just deal with the symptoms for 2 or 3 months because your family and your life are they require your aid and your work. So those are really some of the things that we could change through system level change, is really getting that access to care, having that longitudinal family practice, and that care provider who really knows you. And then geography is a constant challenge in rural areas.
Thank you so much. I think you've raised some really important points just about resources, right? So time is a resource, and then geography is a resource. Maybe now I'll pass it to Trudy.
Thank you. The system resource is, when somebody has a primary care provider, I think that's great. They know you. They know that when you're coming to them, that they're saying that there's something wrong, and you go through all the diagnoses type things. And it's also about a very busy schedule for primary care providers. When there isn't enough primary care providers, you're often taking on too many patients to just try and help that system. So that's a system problem that I think really needs to be addressed. The other would be the referral pathways. I think referral pathways have been incredibly challenging and difficult to primary care providers when there are a whole bunch of different referral pathways, and having that, sorry, you're declined, refer them to here or to here. We're trying to link up on, say, a specialist link, which is in Alberta, and waiting for somebody to call you back, or if they don't call you back, having to constantly reach out and get that information for that patient can be a little bit of a barrier as well. And I also do some rural family practice as well. So it's also about geography as well. If some smaller rural hospitals could have some outreach programs that maybe sometimes patients could be getting treatment in their medical home. So having small cancer units that can maybe administer certain chemotherapy protocols would be very beneficial too. But I think those would be some of the system barriers that I have seen and faced.
Yeah, absolutely. And I think all of us who work in primary care can relate. I've been there with the issue of sending a referral, and you try place 1, place 2, place 3 before you're finally able to get through, and it's incredibly inefficient. I think next I'll pass it to Joan.
Thanks. So my experience is I do the clinical consultations for the gastroenterology service here in the Red Deer Hospital. So I'm kind of often meeting people either coming in through primary care with concerns or patients who've came out of primary care through the emergency department. And when I look at the experience of people that I've met coming through those channels of admission, I think when you look at issues that exist, the entire system is remarkably stressed. Primary care is underserviced at a population base. So a lot of patients don't have primary care physicians. Emergency departments are not designed for primary care. And, Michelle, you really articulate very well this repetitive pattern of coming in with kind of an acute concern into an emergency department that really isn't well positioned to actually address the diagnosis of chronic illness. And yet they're being forced into becoming broader and more experienced in that. But that's in the defense of the emergency physicians, I will say their expertise is in cardiovascular events and trauma and those acute medical illnesses. And so we're really asking them to expand their scope of practice very nimbly, and they're doing it in a pressure cooker, and they're trying hard. And I feel for the patients who sit and they wait and they have to be patient. And it terrifies me that we have people leaving without care, because we know when patients leave out of frustration, it doesn't mean that they left actually healthy. They came and they were unattended to. In Alberta, we have centralized access and triage that exists within Edmonton, Calgary, and now the Central Zone. And that's to really try to address some of the concerns that have been expressed by primary care in regards to these multiple strategies of trying to access tertiary points. The problem is early onset colorectal cancer doesn't fit well into the pathway, because you look at the national guidelines, and really those guidelines sit at the age of 50 where patients populate into screening pathways. And so when you're looking at patients under 40, we're really looking for arguments as to why is a 40-year-old coming into colon cancer screening, like what's going on. And I think this is where and I also participate to a certain degree in CAT. I help it launch in the Central Zone, is asking primary care physicians to really articulate, why are you worried about this patient? Menstruating female with borderline iron deficiency anemia is not an uncommon finding, but why are you concerned about this? What has been the change in the bowel movement? Have you seen previous CBCs or irons? Has it acutely dropped off without any changes in their menstrual cycle? Are they not being able to be iron replenished and actually maintain that? Have you done a rectal exam? We have had conversations about the fact that we believe we need to drop our age on screening. The problem is we have multiple populations coming at us, increased risk of IBD, increased esophageal cancers at lower age. Our cirrhosis population is blowing up in front of us, and that's been a consequence of COVID. And so allocation of resources in endoscopy are getting tighter. They're not actually getting easier to access. We're starting to have some early discussions about, should there be nurse-led endoscopy? Is that an option of doing limited sigmoidoscopy, having different care providers do it? We have rural sites that are providing endoscopy. They're being underutilized. Patients won't drive. And sometimes we're having to phone them and say, I need to let you know, I don't think you're coming in for screening. I'm concerned. You're anemic. Your iron is low. I know we're asking you to drive on a bowel prep for an hour to a different site, and it's harder. But the fact of the matter is we need to get you to care. The other thing that's really unfortunate, though, is we're getting patients through diagnostics, and I've had patients waiting up to 12 weeks to get to oncology, which is heartbreaking because we're not really getting them a pathway to care, and they're presenting back into the emergency departments out of desperation with mental health, stress, anxiety, profound fear, and progressive disease. So I think at a system level, we have a lot of needs for advocacy. I do believe we need to reach into our multidisciplinary teams in ways that we never have before. There's resources in nursing that I think are underutilized. We also need to do a public health campaign in engaging the population in cancers that we can prevent. Canada has had a goal of eliminating HPV cancers in head and neck and cervical cancer. We were on track, and I believe it's in 2021, our inflection point actually went up and we're seeing increased incidence. We have vaccines out there that can cure or prevent cancers. I shouldn't say cure, but they can prevent them. We need to get people aware of that, and we need to really address some of these issues in the cancer population around vaccine hesitancy and look at how do we use our resources wisely, because I don't think they're going to get bigger in the short term. So we need to really target our resources intelligently. Thank you.
Thanks, Joan. You raised some really important points. And I think, as you said, now is the time to think about who is part of the team, right? So really thinking broadly, making sure that all health professionals are working to full scope of practice. We know people often think of doctors, but nurses, NPs, and other roles can play such pivotal roles when it comes to this entire cancer journey. So thanks for raising that point. And obviously people, members of the public, right? And just making sure that they are aware both of how to prevent, but also even thinking about worrisome symptoms. Michelle, any thoughts from you when it comes? I mean, obviously you told us your story, which I think really illustrates some system level barriers and challenges, but anything else that you wanted to add about barriers and challenges to delayed cancer diagnosis for younger adults?
Thanks for asking. I do really think, I think one of the kind of underlying themes that I hear in much of what everyone is saying is really a need for education. I think, so just to kind of clarify, my entry point was into emergency, and I think that they did everything that they could under the circumstances. It was the 3 touch points in primary care after that were very dismissive, where I think there should have been a little bit more investigation, a few more questions. Maybe it's not up to a 36-year-old busy mom who, you know, regularly is running herself into the ground to decide that it's just a locked muscle. You know what I mean? I think there was an opportunity there to investigate, and that investigation simply didn't happen until it was way too late. And so just taking into account how the role of primary care physicians has changed so much over the last couple of decades. And the fact that nobody really told patients that, right? As these changes are occurring in healthcare, nobody is really saying, hey, patients, this is what you should expect, and this is how your role is going to change. And so I think it's really important that as we kind of talk about what these changes are and how that's going to impact all of the different participants in a patient's care, we all need to be well educated and understand what our role is in that, and make space for each other in that co-participation.
Thank you. I think those are excellent points. I think we're too often, even within healthcare, in silos. And I think that's a huge part of the problem, is that we're all kind of operating in these separate buckets when we need to be working together, including with patients and the public. So I have a second question for the entire panel, and maybe we'll go in reverse order this time. So we've talked a lot about the barriers, the challenges, the negative and kind of depressing stuff, but let's kind of turn to the positive and dream big. What do we think could be done differently to improve the current situation and to strategize for a path forward? So let's reverse order. Maybe start with you, Michelle.
Yeah, really just kind of emphasizing that final point, right? It is just treating each other as though we are co-participants in care, and making sure that communication is open, that curiosity is a big part of that conversation and that relationship between physicians and patients, and making sure that as system changes are occurring, everybody involved is well aware of those changes, so that we can play the part that we need to for the benefit of everyone.
Yeah, thank you. I often hear people say that we talk about, you know, healthcare system, primary care system, but often we're not a system, right? We're just these separate parties. So I totally agree with that point. Joan, any thoughts about what we can do differently to improve the current situation?
I think at a public, like at a patient level, and I really appreciate what Michelle said, that one is it's difficult to be a patient, and especially in the current system. I think it would be worthwhile having education or messaging out to the public on how do you prepare for a visit with a healthcare provider? How do you sit down, think about why are you going? What is it that you want to address? How do you want to articulate it? Michelle, you're remarkably articulate. And I think when I look at people presenting into the system, people who have limited literacy or language capacity often don't get as good of care because they just can't tell you as well what's going on. So we just slow everybody down. Why did you come to the clinic today? Like, what is it that you're wanting to make sure that you have addressed? Those should be written down points, because sometimes you walk into the room, you've waited 15 minutes in a gown with a little paper sheet over your legs, and you're terrified about what's coming in next. Somebody you've never met before walks in and says, "Can I help you? Help me understand why you're here today." And you're all of a sudden frozen in that moment. That really actually doing a little bit of work to prepare and coming in with that defined, I think would be at a patient level sometimes helpful. At a system level, what could we do? I think we do really have to engage into those multidisciplinary resources. Edmonton has an excellent nurse practitioner who has done, I think, endoscopy for almost 20 years. She has one of the highest rated report cards in colon cancer screening. She is the lowest cost endoscopist in the country. And I think she scopes 4 days a week. She does a brilliant job. Is that a threat to the monetary gains in medicine around endoscopy time, which is quite lucrative and highly valued and coveted? Absolutely. But how do we look at maybe things like nurse-led endoscopy, really engaging into sigmoidoscopy programs? There is bench research that's currently going on looking at clinical biomarkers in stool that would predict colorectal cancer or risk of adenomas. I think we need to lean into that because we need to try to reduce probably the population of people that are coming to endoscopy to really high yield scopes. I think we should be reflecting on our current endoscopy lists and identifying what are low yield scopes, and then we need to identify really where are we putting that resource if we're going to utilize it. So I think there's a few things we can do both at the patient level and then as we move into clinical and also into research that would move things forward.
Excellent. Thank you, Joan. And I think those are all for both you and Michelle. They're very realistic suggestions, right? These are not things that are impossible or require an infinite amount of resources, just rethinking how we do things. Trudy, I'll pass it to you.
Hi, thank you. I agree with everything that Joan has said from a system level, and I won't add really to that kind of stuff. When it comes to even like patient and primary care provider relationships, right? I think it's about not dismissing our patients anymore, right? Just based on age. Looking at even, the basics of certain labs that come back with iron deficiency anemia, right? We can't just say because you are of a certain age of childbearing or perimenopause that that's what it is. We should all be investigating that IDA fully for any patient who comes through your doors. So utilization of labs and markers and things like that are helpful. Better education or maybe even just language to our patients about, I need you to get this blood work done. I hear what you are saying, and I am just as concerned as you are. It would be helpful if you went to the lab today, or it would be helpful if you got this done. And often I use the language of I am very concerned, and I am ruling out the scary things, which can include cancers. So, getting back to the base, like just getting back to being able to just say that to a patient, have that comfort level to a patient, and then also be able to reciprocate any reaction that you might get from a patient from a very compassionate standpoint and comforting. And then, like Joan said too, right? You're going to leave here and you're going to have questions. Write them down. I'm going to book you in right now to even come back in a week so that this isn't forgotten about. I think is really, really helpful. So just getting back to having better relationships and better communication with our patients. And I think that can be really helpful. When we think of system things, right, and I'll speak to more primary care because it is quite stressed. There isn't enough primary care providers, and specifically for Alberta and across Canada, but I'm more in tune with kind of Alberta and their stats. Just a few short years ago, it was estimated that about 800,000 people did not have a primary care provider, and that's astonishing. They had then implemented nurse practitioners to now finally do primary care, which was very helpful. There's now 70 practicing in Alberta, which equates to about 70,000, and obviously have plans for growth for that to just help with that primary care crunch. And you're seeing now more programs come across Canada for nurse practitioners to just do their scope of job and not be restricted in that scope of job, which I think is going to be helpful eventually. Other thoughts too is I do think younger patients will think, well, that'll never happen to me. I'm too young and I don't need a primary care provider. Having those national ad campaigns on TV, I think could be really useful, very helpful. I'm sure that they do those to just engage the population who maybe is unattached as well, to say, hey, you should have a primary care provider too. Or even ad campaigns about cancers are happening in younger individuals. You should be aware of this as population. Other points that I'd kind of thought about is even university level education. I can't speak to, I haven't been in school, I haven't looked at the curriculum necessarily for nurse practitioners or for MDs, but what are we teaching our students who are going to be pioneering and coming out about cancer rates happening in younger individuals, and about how we are already thinking about changing guidelines, changing age categories? Is that being taught in our universities? Because as they come out of university, they're already going to then be thinking about it. Thank you.
Thanks, Trudy. And I think you ended with an excellent point. When we think about the newest generation of health professionals coming out, we need to make sure that they're aware, right, of these epidemiological changes that we're seeing in cancer rates, because that's crucial, because they will be the future of medicine and healthcare for decades to come. Dr. Dillon, let's turn to you.
Sure. Yeah, I think there was a lot of great points that made me even think a little bit, but I think one of the things that really ties it together to me from the patient experience there, and then some of the stuff Trudy was saying, is I think as much as it's horrible as a patient to hear that word, like, and I just think about it for my own family, like, when is the day going to come when someone in my family is going to have to be told that, you know what, you have cancer? But I think about it as a step before, where we as the physician may have some sort of inkling, and through the history or the physical or the gut instinct, that something isn't right with this patient. And I think Trudy talked about this as well, is like when we communicate that to our patients, we're wondering about it in our heads. And I think that's the first step that comes to the education piece. Epidemiology has changed. We're probably not teaching it at the edge, like at the scientific edge of what's happening in the Canadian population across the country in medical schools, because we're saying, oh, colorectal cancer, this is when screening starts. So subliminally, we're saying, well, why are we checking or worried about it before? So there is an effect of saying screening starts at 50 till this age, and then you're done. So I think ongoing education, I think the piece there is, it's for us as physicians, it's not something I ever want to say. So Trudy said it, and I think it's probably physicians across the country. We use different words to, not increase like the amount of fear around it possibly being cancer early on, because I think we hope more than anything that it's not going to be cancer. Like when I have to give a diagnosis in like a rural emergency department to someone who I've spent 3 minutes with, go away, do some tests, get some tests back, and I go like, this is not going to be good, or I do the CT scan and I have to go give that diagnosis in an emergency room to someone who I've known for 120 seconds. Like that's the amount of time I've spent with them. That's challenging for us. And if you roll that back to say, this is the first time that they're coming in with hip pain and we're worried, but we still need to do some tests to figure it out. We may have to shift our language to start just saying, you know what, like raising, unfortunately, the patient's concerns just to get them to go and get that extra test, and just start saying cancer instead of I'm concerned. And I'm sure Trudy would use some sort of language or like, you know, I'm really worried. This could be something. I'm not sure, but let's go get these tests. And maybe in some of these younger adults, we're gonna have to just start using the cancer word a little bit more, and talk about our personal experience about how we've had to diagnose cancers earlier and earlier. Just this morning, the first conversation I had this morning was with my wife about one of her friends who is, and we're young enough, we're still like late 30s, early 40s, who's going through chemotherapy. And like, it's such a different experience when you're younger and beginning life or in the middle of life, to later on. So I think the education piece and the ongoing education piece is going to be absolutely essential. And the other piece, someone talked about it there when they talked about co-participants in care. And I think the other little very unique elephant in the room is how is AI and the amount of knowledge that patients can come in with. And people talked about, you know, sitting down and having your thoughts and know what you want to come in with. I'm using it like a little bit more. I'm a little bit older, so I'm not as on it as some young people. But it's like, it's very interesting when you use AI to say, what could this be in this patient? And what are the deadly things it can be? And I think with that, we'll have a little bit more insight and possibly having some of these conversations a little bit earlier where a patient may come in and say, you know what, I really want to either rule this out. And then we have to deal with the downstream effects of way more investigations, way more care needed to rule out cancer as well as rule it in. So yeah, so on a positive, I think education, absolutely essential, both in university to the patients. I think that's a great idea, but then also ongoing for physicians.
Thank you so much, Dr. Dillon. Those are great points. And I think, you know, everybody is pretty aligned as far as key elements that could come in the future. You raised AI, which I think could be a whole other full day symposium, but I think we need to think about how patients are using AI tools, often turning to AI if they're feeling let down by the healthcare system, and then how we as healthcare providers can use AI to help us provide better care. So thank you for raising that key point. So those are kind of our two big questions that we had for the panel. We will have lots of time now for Q&A, but before we go to the Q&A, I did want to give Michelle, you did such a great job kind of setting the stage to open things. And now that we've had some of this discussion, perhaps I could ask you just to provide some reflections before we turn to the Q&A.
Sure, thanks for the opportunity. Really great discussion. I think there are some really important elements that have been raised here in terms of like physician and patient relationship. That's a great key point there. And communication in that relationship is really important, and not just in, you know, the terms that we use. And like Dr. Dillon said, there are, you know, depending on the patients that you're dealing with, maybe that language needs to be adjusted a little bit and the approach could be adjusted a little bit, but also just getting out of expectations and into curiosity, really. And I think just that simple step, I mean, I say it's simple, but we all know behavior change isn't really that simple, right? But just to have the mindset going into conversation of curiosity rather than expectations would really help in earlier detection. The other thing that I'd like to just kind of call out in the conversation as well is that yes, education for all would be great at the university level with physicians, patients, everyone else, and on an ongoing basis would be great. But we do also need to keep in mind and be empathetic to ourselves and everyone else in the system too, that it is an overwhelmed system and there is a lack of primary care physicians, and this is causing a phenomenal amount of strain on, you know, the physicians that are in practice and our emergency room friends and all of, you know, the other healthcare providers who are supporting patients, and of course patients as well. And so I think it's just really important that we keep sight of the the achievable goals, and also, you know, be resilient and persistent in the opportunity for bigger system change, but also just holding space for the fact that we are all humans having very human experiences, and it would be a whole lot easier and gentle, respectful, compassionate if we just held a little bit more space for each other as well.
Thank you, Michelle. That's a great reflection. What you were saying reminded me, I don't remember the exact expression. There's an expression that's something like nothing kills curiosity like a quick diagnosis. Because I think often we're quick, right, to make a diagnosis. Oh, you're young and you've got hip pain, it's MSK. But the reason is because of what you just spoke of. There's maybe a whole bunch of other patients in the waiting room after, and we want to rush and get through to the next person to get through the day. So I think that giving grace to all of us, patients and providers, and thinking through how can we create spaces where people have the time to be curious, I think is going to be really, really key. So thank you so much for raising those points. I will turn it now to some questions that have come through. So let's see here. This first one is going to be for Dr. Dillon. So last year, CCRAN's patient survey identified a number of patients who received their cancer diagnosis in the ER, just as Michelle experienced, and you spoke to this not too long ago. Dr. Dillon, could you speak to your experience with diagnosing patients in the ER and what impact the shortage of primary care providers has on this?
Sure. Yeah. So it's a challenge. I mean, I can think about at least twice within the last year or probably 6 months where this has had to happen. And there's two sides to it. One side ends up being a surprise sometimes to me, and other ones where I kind of finish my patient interaction, I go back, order tests, and I go like, I don't like where this is going to go. And it comes down to patients coming in and saying, I've had this going on for a while. I'll keep it generic. I've lost a lot of weight. After COVID, I never had my family doctor, and I've just been kind of dealing with it. And here's my symptoms. And I walk away going, this is not going to be good. Try to keep it positive because I'm not sure. And then get a test, say a CT scan is probably the best example in this case. And then I get the results back. And I know when, say, the nurse has read the report already and they come in and you can see it's just deflating. And then I have to take some time to then read the report, figure out how bad it is, and then try to go back to a patient once again that I've just met, and they may have an inkling or they may have no idea. And I'm about to, take them from having a day where they thought they're going to come into the ER, finally get some care, into possibly the worst day of their life. And then the challenge in the ER is there's other stuff going on almost all the time. It's not a quiet, peaceful environment. You've got 2 walls and a curtain. And I have to come in and sit down, and then all of a sudden the questions start, like, how much time do I have left? And a lot of that stuff, like, I honestly don't know at that stage. And trying to give that incredible volume of information and funnel it down to the one patient who is honestly going to remember probably 1 or 2%, if that, of what I say in that moment. So that's a huge challenge. And then the next piece, and there's some improvements in BC now, but what do I do to that patient or what do I do for that patient who didn't have a family physician, is seeing me in the emergency room? I've given them a diagnosis. Where do they go? Right? And that's a huge challenge. So, and that, I think every community is a little bit different. Most physicians, like, there's someone who will take that person on, but then all of a sudden you're taking them on at a really challenging time with, and like not knowing how it's going to go, and you're developing a relationship in a very challenging time. So it's like, it is not the optimal environment for that. Now, that being said, no matter what we do, sometimes that's where you're going to get your diagnosis, but it really shouldn't be the majority of patients finding out in the emergency department. It's just not the right space.
Yeah, exactly. I think, as you said, there's always going to be those circumstances, but it certainly shouldn't be normal. Because often, as you said, when people first hear, it's kind of like you just hear that white noise in your ears, right? And you have to absorb it. And then where do they turn to? And they've left the emergency room. They haven't yet seen the specialist, and they've got all of those questions. Trudy, please go ahead.
Hi, thank you. I've actually had some experience. I know Calgary specifically was looking at this, how many patients were showing up into the emergency department without primary care providers and being given a devastating diagnosis, and getting them attached obviously to oncology, but then how do you attach them to a primary care provider? They're looking at launching, I don't think they have the funding yet, but they are looking at launching a whole program for that, where they're going to take 2 nurse practitioners who'll take on those patients in the emergency department. They'll get all the extra testing that is required for that, get them to the right oncology group, and at the same time getting them connected with a community primary care provider who then can also then take that on going forward. So I know they are looking at different systems for that in Alberta. I know it hasn't been launched yet, but I'm hopeful that there will be funding for something like this, because it's desperately needed.
Thank you for sharing that example, and hopefully in the future we'll be hearing more about it, because it sounds like a really important innovation that hopefully could be spread and scaled if it's successful, which I think it would be. All right, our next question. There are so many stakeholders who want to help with this issue. How can patient groups, clinicians, professional associations, and policymakers better collaborate together? Does anyone want to take this question on?
I actually think a symposium like this is an excellent forum for people to be able to really kind of have these shared experiences, because everybody has an optimistic lens. We all want to do better in a system that really around us is limping. And I mean, I completely can feel Dr. Dillon's discomfort in talking with patients about diagnosis. I mean, I think of just last week going up onto a nursing unit with a patient that was being housed in a hallway on a bed and saying to the nursing staff, like, I know we have every flat space in this building is at like 130%. I need an unlocked office door, a place somewhere, or I'm taking him and his wife into the bathroom and I'm going to sit him on the toilet and I'm going to sit on the sink and we're going to have a chat, because this is a bad diagnosis and we're not doing this in the hallway. And she kind of looked at me and she's like, we'll find you a room. But it's almost that bad. And we all want to do better. Patients want better of us. We want to do better. Our research community wants to do better. And advocacy wants to also work. I think we just need to coordinate that. We need to engage with leadership in healthcare. And at least in Alberta, that's getting harder and harder every day to understand who that is. But we need to come back to them and say, you know what? We're not okay at a very broad level. The patients aren't okay. We're not okay. We have things we could do better, but we do need some system structures and resources to move us through those processes. 3 years ago in Alberta, we had different strategic care networks that worked at a provincial level, and they did overarching program planning. I think groups like that are useful, where you actually have different disciplines come together, including patients, and speak about really identifying what are the targeted priorities at a broad provincial level, identifying them, and then really making those your focuses of communication. And as you start to have success in moving things forward, you revisit where are your next set of priorities. And I think it makes it easier to lean into provincial leadership around really what are the things that you should focus on, because you have quorum. And I think if we could try to recreate those type of strategies at a national level, I think it's helpful. The problem is every province is organizing their actual delivery in different ways. So I think it almost really has to be, maybe some of the messaging is at a national level, but it really has to be implemented at a provincial strategy.
Yeah, exactly. I mean, I think we do need to recognize that we have separate provincial healthcare systems. So we have to acknowledge that reality and think about a unified messaging, but then implement in a way that suits each provincial context. So our next question, so Joan, you had mentioned HPV vaccine. So lack of financial coverage for HPV vaccine is a significant barrier for those older than 26 and willing to vaccinate. And the question is for anybody on the panel. What steps are primary care providers taking, or what steps could they take to advocate for access and prevent HPV-related cancers?
And I can start with that one. I mean, it's hard to say like when I would find the time in a day to then throw in advocacy for one particular thing. If I was to look at it at like Dr. Lofter just said, it's a, you know what, maybe it's getting the local physicians in your community to sign a letter advocating for that, and then taking that to your local MP or MLA, depending on what province you're in. I think that would be the most effective way, because you're going to be very challenged to find physicians who are going to have extra time to do more advocacy on targeted things. And I think it then has to come up to, you know what, say like a provincial organization then can have the signatures and the support, at least the tacit support of the physicians. That would be my like strategic level thought about that particular question. I don't think you're going to find a physician that's not going to support it.
Yeah, agreed. Michelle, you got your hand up. Please go ahead.
So I love everything that Dr. Dillon just said. I would also say that recognizing really how busy physicians are, really how busy healthcare providers in general are, there are also lots of really great organizations out there who are willing to do that organization for you. And so I think it's also like really beneficial to be connected and understand who the patient organizations and, you know, networks and alliances and coalitions are that are out there who are resourced to do that kind of work on your behalf. It might just mean that we need a little bit of collaboration from you. It might mean that we need a little bit of your time, but it doesn't actually have to fall all on your shoulders. There's a whole community of people out there who are happy to help move those things forward with you.
Yes, thank you, Michelle, for raising those points. And I think if we think about politicians listen to their constituents, right? And patients are constituents too. So I think patient groups are so good when it comes to advocacy. And I think it's just ensuring that they've got healthcare support. Trudy.
I won't add to those points, but going back to even just patient relationships and really good communication. I know it's really hard in a very busy day, but even with every well child check, I do ask about immunizations. And if they're approaching that grade 5, grade 6 HPV, it's about educating parents about what that vaccine is actually for, so that they don't maybe, you know, say no to it. I also think it's about education for, you know, teenagers too, engaging their maturity level, right? Because oftentimes when you're doing certain assessments, the patients are, their parents are out of the room and talking about different vaccinations and saying, you know, when you do turn 18, or if they're approaching that age of 18, that you now have that choice to have that vaccination. And I've had pediatric patients who've aged into that age group and have asked then, how do I get that HPV vaccination? And then it's just that connection to public health. So it's not sometimes just that vaccination, but it can be actually many vaccinations. So I think it goes back to, how do we also educate the public again about vaccinations and their concerns around it, and how do we ease their minds on it?
Yeah, exactly. People have so many concerns these days. So how do we communicate effectively? I think we've lost the effective part of the communication often. Joan.
Just one more comment in regards to coverage for vaccines, and this is something that potentially could be addressed at the advocacy level for the adult patients over the age of 26. Governments provide vaccines, and I think we know the strategies there. I think we also understand some of the difficulties of kind of banging on that door. The other place that you can get vaccine coverage is through employers. So when you look at health benefit programs through third-party insurance, it may actually be going to programs like Sun Life, Manulife, Green Shield, talking to them about the value of adult vaccination for these preventable cancers and looking at making that a health benefit associated with employment. Also talking with employers in regards to benefit programs where some employers have health spending accounts and vaccination can be covered through those. And an example that we're kind of seeing right now in Alberta is our younger population that wants to get COVID vaccination. If they're submitting their vaccine, what they've had to pay for that through to their third-party insurance. Third-party insurance is covering most of those vaccines, I think with the exception of the $20 injection fee. So that would be the other strategy to look at around cancer prevention, is pushing into the employment, because large companies buy group insurance for their employees through those programs. They do tend to try to follow the non-group programs that are done provincially, but a lot of the bigger companies will have higher end either health spending or coverage things that can be negotiated. And I think that could be advocated for through patient support programs looking through those insurance companies.
Excellent. Thank you for a really practical point, and I think one often as providers we're not aware of and not thinking about when people come to us with those financial questions and concerns. So let's squeeze in one last question, the last couple of minutes that we have. We talked so much about communication. Does anybody want to comment about kind of any practical tips about ways we can improve communication between shared care teams, primary care, emergency departments, after-hours clinics, and family doctors? How can we, and specialists, of course, how can we improve those communication pathways?
I can
Go ahead.
start. I mean, over the last 10 years, it's definitely improved. At least at the provincial level, I can only speak, I think, vaguely about Alberta. I think there's Care Connect there. So at a provincial level, it has improved. It's not seamless. And I don't really think it's fair to push it down to a patient to kind of walk around with a file folder of stuff or a USB, which isn't going to plug into different computers. So I think the onus really has to be on the system. There have been improvements, but these are multi-billion-dollar, ultimately, like software data networks that are going to have to be implemented. And they're still not, they're not patient-friendly and they're not physician-friendly. I don't think you're going to find many physicians who'll say proudly every morning, I can't wait to log into my electronic medical record that's linked in for the new patient who just came from Ontario with a diagnosis and has moved home for patient and family support. And you're asking for a fax number in 2025 to get permission to get the records from someone else. And then you've got a 328 page PDF. That's a real story from this week. So yeah, I think it's very expensive, very challenging, but I think you'd find that you can do way better data and research, and then also provide better patient care if we had that.
Thank you so much. I also am a bit baffled that, you know, everything that's happening in technology in the world, but yet we still rely so much on fax machines within the healthcare system. It is a little bit mind-blowing. I see that we've just got 1 minute left, so I am going to just wrap it up and first of all say thank you to each and every one of you on our panel. It was a really rich discussion. I think we raised some really important points around communication, around who are part of our care teams, people working to full scope, how we can use technology to improve our systems and create healthcare systems, how we can increase access to resources, which will then ease load on primary care, which will then ease burnout, which will then, I think, bring us back to a space of curiosity, grace, and openness. Thank you in particular to Michelle for sharing her personal story, because I mean, that's not easy to do, and we really appreciate you doing that for us. And thank you to everybody for a really rich discussion. I'll pass the mic back to Cassandra.
Thank you so much. You know, we were really, really keen to engage the primary care community for the symposium this year, and we are so incredibly grateful to each and every one of you for joining this discussion. And, you know, there's been some really wonderful points highlighted. I do just want to very quickly touch on the physician advocacy piece and the high level of burden. And I really just want to echo Michelle's message, which she said so eloquently. But to the primary care community, you know, patient groups stand ready. We want to help. We want to collaborate. There's so much to be done, and if we can break down some of these silos, we can make some progress and improve awareness and education about early age onset cancers. Ultimately, you know, get patients to their diagnosis quicker. So with that, thank you to all of our panelists here today. And as we head into our first health break of the day, I invite our viewers to take this opportunity to, you know, grab some lunch, maybe take a movement break, and enjoy the featured videos that will be playing. We are back at 1:15 Eastern Time for a panel discussion dedicated to reframing the value of cancer, early cancer detection in younger adults. And we'll see you then.